from FDN. So my name is Dr. Stephen Howie. I'm a pediatrician and associate professor of pediatrics at the University of Auckland in New Zealand, and I'm the technical lead for Cure Kids' Fiji Oxygen project, which works closely with the Ministry of Health and Medical Services and other agencies to improve the availability of oxygen and respiratory treatments in Fiji. And the ministry has asked that training be done in oxygen and respiratory care. And so we've got a really good team to help us do that today. And I just want to introduce you to our trainers today. We have Dr. Shanjavan Padarath, who's a clinician based in Suva. Shanjavan, you can wave there if people can see Dr. Shanjavan. And he's project manager of the Fiji Oxygen Project. And we have Dr. Aquila Nangasimo, well known to many of you, anaesthetist and intensivist at CWM Hospital in Suva. Dr. Aquila, if you feel like waving, go ahead and do that. Sister Lavinia Karikaritu is a senior ICU nurse at CWM, again known to many of you. We have Beth Price, who is with the Australian Medical Assistance Team. She's an ICU nurse and she's on the ground there at the moment, training a lot of people on related subjects in Fiji. And we have Anthony Cook, who is from the WHO emergency medical teams. He's a trainer and he's a consultant for the Pacific. And he's got a background in emergency and intensive care nursing. And we have Dr. Erin Nost, who is also a WHO emergency medical teams trainer and consultant for the Pacific. And she's an emergency medicine doctor, and she's based in the US. So by way of background, we're doing this webinar to support the Fiji COVID response. And this is an outline of what we're going to be covering today. We'll start with a bit of a COVID update, just explain the goal of training. And a lot of this is based around the FEMAT guideline for treatment. And so we'll be looking at that. Then we'll be moving into some case-based teaching and learning around respiratory status assessment, pulse oximetry, how do we detect hypoxemia? How do we detect mild symptoms, categorize people in that way, and what treatment they may or may not need, and then more severe cases, moderate, and treating them with low flow oxygen. We'll be talking about oxygen sources from concentrators, from wall outlets, from cylinders. So those are the things that we're going to be covering today. And we'll be covering today in this webinar and in the next, low flow treatment with oxygen and then high flow treatment with Airvo. But today we're going to be focusing on assessment and low flow treatment. So do remember to ask your questions in the chat or at question time. So by way of COVID update and an introduction there. So we all know that there is a pandemic that is raging around the world at the moment, and it's caused by this coronavirus, SARS-CoV-2. Now, in this global pandemic, there have been over 200 million infections, over 4 million, widespread disruption to populations, to health systems, to economies. Nobody in Fiji needs reminding of that. And this is a map that just shows the distribution of this. And there's nowhere that's untouched by this pandemic. Now, it's spread, as you know, by droplets and by aerosol and stay on surfaces. Mostly it's person-to-person spread. And it's prevented by COVID-safe practices. Now, here you see somebody in PPE. Now, that's very important. Hand hygiene, cough and sneeze etiquette, wearing masks, just wearing those masks, wear those masks. Good ventilation, social distancing, here's a mask there. Always remember, wear your mask. The PPE you saw, and vaccination. And Fiji's making good progress on vaccination, and it's good and it's safe. And we just really want to encourage everybody to get vaccinated as soon as they can. So remember, wear your PPE. Now, overall, for COVID cases, when people get sick, about 80% of those cases are mild or moderate. 20% of them are severe. Around 15% of those will need oxygen treatment. About 5% will be more critical and require more than that. So we're going to be focusing on the ones in these webinars that need that treatment, distinguishing the ones that don't, and then we won't be talking about ventilation, which is a step above that. So it's pitched at that level that doesn't require that. So just the background and the update on COVID in Fiji at the moment. Thank you, Erin. So you guys are looking at the updates frequently, I'm sure, and we won't go through all of this. We just want to say that since the outbreak started in April, there have been over 40,000 cases, over 400 deaths. Now, vaccination, as we say, is going along much better than it is in many places, and over 90% of the population, the eligible population, have had one dose, 40% or more with 2 doses. So keep going. Well done. Keep going. Thank you, Erin. So the goals of this webinar, as we've already touched on already, we're focusing here on hospital-based care, particularly for those who find themselves in a situation where they're having to manage patients that perhaps in their area that they perhaps wouldn't have to otherwise, and intermediate care areas like those run by FEMAT. And we're focusing on the recognition of those who need intervention, those who have hypoxia, who've got a low blood oxygen, and those who need oxygen treatment, either by nasal prongs or Hudson mask. And next time we'll cover Airvo. We'll look at those oxygen sources that we mentioned, and we'll cover that low flow this time and the high flow next time. So with that, it's time to hand over to Dr. Erin and Dr. Aquila, who are going to take us through the FEMAT guideline and then lead on into more teaching and learning around assessment and treatment. So I'll hand over to you both.
Thank you so much, Dr. Steve, and Bula Vinaka to our audience. Thank you so much for joining us this evening. We'll now review the FEMAT guidelines, which will serve as a template for how we approach a patient with COVID-19 symptoms. This guideline is a simplified approach to patients with COVID-19 that is based on the national standards. It divides patients into 4 different categories, depending on their severity of disease. Now, this guideline is for the adult patient. And as we're talking, we're going to be primarily talking about the adult patient with COVID-19 over the session today, as well as next week. If we look at the guideline, and our first section is the mild, which is seen in the yellow color. These patients aren't typically working hard to breathe. They have a respiratory rate that is less than 24, and their oxygen saturation is greater or equal to 94% on room air. They do not require supplemental oxygen. These patients will then have further assessments to determine their proper disposition. Where do they need to go? And that would be determined by the clinical team. But overall, when we're looking at just the respiratory status and their oxygen saturations, they're not requiring oxygen. The moderate category are for the patients that have this increased respiratory rate or have lower oxygen saturation, and that's seen in the blue section on the slide. Typically, these patients have a respiratory rate greater than 24, or the sats are less than 94% on room air. These patients typically do not have the signs or symptoms of respiratory distress, but do require that supplemental oxygen. These oxygen can be placed by either a nasal prong or by a Hudson mask, depending upon what's available. Now, our discussion for this session will focus on these 2 categories of mild and moderate symptoms, as well as the oxygen sources that we can use to treat these moderate symptoms that require oxygen. Our session next week will cover more on this red severe category. These are the patients that have a high respiratory rate, have low oxygen saturation of less than 94%, but have also signs of respiratory distress, such as labored breathing, speaking in short sentences, tripoding, or sweating. So the last category is going to be this gray critical, and this is going to be outside of the scope of our discussion this week as well as next week, because these are the very, very critically ill patients that have a significant oxygen need and typically require mechanical ventilation. So Dr. Aquila, any other additional comments or thoughts on the FEMAT guidelines in your approach to the COVID-19 patient?
Thank you, Erin. So it's just maybe just an addition to what you mentioned already. These schematic guidelines is sort of a simplified algorithm based on the national guidelines. The national guidelines is now on version 9, and that might be part of the presentation tomorrow, if I'm not mistaken. But otherwise, the version 9 has the algorithm for the national scope, and this is just a simplified version of that. It doesn't have specifics on medications, for example. But yes, thank you. And this was adapted from with the help of Dr. Jara as well, who's actually in the FEMAT at the moment.
Thank you so much, Dr. Aquila. So our next step in our kind of assessment, or how do we approach a patient, is to actually assess the patient's respiratory status. As an emergency physician, I typically put in patients into really 3 categories. I like to kind of approach the patient initially in a very simplified manner, and that helps me risk stratify. Are they sick? You know, I'm really concerned about the patient and I need to do something to help. Or essentially not sick. So these are the patients that are talking, can have a conversation, have normal vital signs. I can kind of approach further. So those are like the big 2 categories I have: the sick, not sick, and then I have this third category of, should I be worried about this patient, or could they be sick? And that's based upon other signs and symptoms. I approach the assessment of a patient with respiratory complaints essentially the same way. So I look at, do the patients have signs and symptoms of respiratory distress, or are they stable and breathing comfortably? Or do they fit into that third category of, they're not incredibly sick and crashing where I need to do emergent treatment, but they have some signs and symptoms that make me more concerned that they could have something potentially wrong and need more respiratory support. So when I initially approach a patient and do a respiratory assessment, my first is I look at the patient and see how they look. Are they working hard to breathe? What do they look like? Then I'll take a step back and look at their vital signs as well and pay particular attention to a patient's respiratory rate, oxygen saturation, and heart rate. So if the patient is breathing fast or is working hard to breathe, they may have a fast heart rate. And if they have a fast heart rate or tachycardic, then I may be more concerned about their general illness with their respiratory complaint. Next, I'll assess their respiratory rate. So how fast is the patient breathing? We can determine the respiratory rate of a patient by counting how many breaths a patient takes over 30 seconds and multiplying that by 2 to get you your breaths per minute. Normal adult respirations should be 12 to 20 breaths per minute. Anything over 24 should raise your concern that the patient has something significantly wrong with their respiratory status and needs further assessment and treatment and stabilization. Next is our oxygen saturation. Now, this is particularly important to assess really quickly on our patients that are presenting with COVID-19, as these patients can have pretty profound hypoxemia or low oxygen saturations that does not typically match how they're presenting. I've been really surprised multiple times throughout this pandemic when I'm assessing a patient with COVID-19 who's coming in with some complaints of shortness of breath, some cough, doesn't feel great. We put on the pulse ox and their oxygen saturations are in the 70s. And you're like, wow, like we need to get oxygen on this patient right away. So, you know, it's really important to get that oxygen saturation, that vital sign really early on, particularly in these COVID patients, because we do know sometimes they can be talking to us, but yet have pretty profound hypoxemia we need to act on. So these patients that have oxygen saturations that are less than 94% and do not have chronic respiratory diseases like COPD that are coming in with COVID-19 symptoms should be placed on oxygen right away. So we're going to watch a quick video on how to place and read the pulse oximeter.
One, ensure that the patient's finger is free from nail polish and artifacts like acrylic nails and beads. Press the power button, arrow, to turn on the pulse oximeter. Place the probe on finger. Step 2. Wait for the proper pulse waveform to appear as shown on arrow. Now, recording the patient oxygen saturation or SpO2 and pulse rate. Step 3. Immediately notify the nurse or doctor if the patient's oxygen saturation or SpO2 goes down to 93% or less in room air. Step 4. Put patient on a simple mask and turn on the oxygen to 5 liters per minute. Continue to monitor saturation or SpO2.
Great. I will hand it over to Dr. Shanjavan to review the details of the steps that were outlined in the video.
Bulavadaka, everyone. Thank you, Erin. This is one of the few posters that we have tonight, and we'll circulate to all the health facilities. So we try to make everything into 4 steps. The first step is to ensure that the patient's finger is free from nail polish and artifacts like acrylic nails and beads. Press on the power button and place the probe on the finger. So in this picture, you'll see that it's the Life Box, which is one of the famous yellow pulse oximeters that you may have in your facilities. You may have other types of pulse oximeters too, like the fingertip ones, or even the ones that come from the monitor. Second, you wait for the proper pulse waveform to appear, as shown in the red circle above. Once that waveform appears, you know that you've actually got your oxygen saturation and pulse rate. Step 3 is immediately notify the nurse or doctor if the patient saturation goes below 94%. And once that happens, you go to step 4, which is to place a simple Hudson mask on the patient and turn on the oxygen to 5 liters per minute. Remember, whenever you're giving oxygen, to continually monitor the patient's saturation. And in this case, we've advised to use a simple Hudson mask, but of course you can use nasal prongs as well, which can deliver up to 4 liters per minute. Use whatever you can in your facility. We've tried to make these posters as simple as possible in case the pandemic worsens and anyone and everyone is able to use a pulse oximeter. Thanks, Erin.
Thank you so much, Dr. Shanjavan. So we have our vital signs, we've checked our pulse ox, we made sure that the patients don't have this profound hypoxemia that we know our COVID-19 patients can present with. We can also now continue our assessment of our respiratory status. So there's some additional signs that I look for when a patient is having difficulty breathing or they're complaining of shortness of breath. So first, I look and see if they're using their accessory muscles. And this can be seen in the picture at the bottom of the screen. Now, this gentleman looks like he's pretty scared and he's working really hard to breathe. But this is actually a pretty good depiction of what a patient looks like when they're in pretty profound respiratory distress and they're hypoxic and struggling to get the proper oxygen into their body. They can look very anxious. But you can see also in this picture that you can see a lot of his muscles, of his accessory muscles that he's using to help him breathe. So you can see the accessory muscle used sometimes in the neck, And you can see kind of them helping get that kind of diaphragm in their lungs up. You can also see patients that are using their intercostal or the muscles in between their ribs to help them breathe. And you can see them really moving hard. So if you see anyone using accessory muscles use, that's a big red flag that this patient is in respiratory distress and we need to do something. We need to help them. Additional signs are, patients just are generally labored, to look very tired and like they're working really hard to breathe. Additionally, patients can come in and only speak 1 to 2 word sentences because speaking a full sentence just takes too much out of them. Additionally, patients can be tripoding. This is essentially similar to the accessory muscle use. So the person is trying to use as much other muscles to help move that diaphragm and open up their lungs to get air into it. So you're either kind of supporting yourself by a desk or on your own legs, and you're kind of working hard to get that breath in. And then the last thing I look for, and that I always get nervous about in the emergency department when I'm assessing a patient, if someone is coming in and they're profusely sweating, I tell my emergency medicine students, if you see someone with profound diaphoresis or sweating, be concerned, because you cannot fake this. And if they are working that hard to breathe and they are sweating that profusely, you need to start moving and be doing something for the patient as well. And then Dr. Aquila, you've done tons of work in the ICU with patients in respiratory distress. Do you have any other kind of tricks that you look to when you're assessing a patient from a respiratory standpoint?
Sorry. So we sometimes see from ICU the other end of the spectrum, where they actually not so distressed. The GCS level falls. So these are patients who are beyond this point, and they actually they're semi-comatose. So you can see from this point, the next step would be either they have a respiratory arrest, or they can be semi-comatose.
Great, that's a great point. Definitely, if you're tripoding, you're using your accessory muscles, you're breathing fast, you can only do that for so long, and these patients will tire at some point. And that's the kind of the more extreme end that Dr. Aquila is definitely familiar with in the ICU. So now we're gonna we talked about how do you assess these patients, kind of the overarching guideline that we're using to determine when patients need oxygen with the FEMAT guidelines. We're going to go into a patient case. So our first case is we have a 45-year-old male who's presenting with cough and shortness of breath for the last couple days. For about 3 or 4 days, he has had some subjective fevers. He's feeling feverish. He's able to talk to you in full sentences. We get our triage vital signs because we know they are pretty important. The patient's temperature is 38.4 Celsius, blood pressure is 128/92, heart rate's 92 beats per minute, respiratory rate is 18 breaths per minute, and the patient's oxygen saturation is 96% on room air. So I'd actually like to ask the audience, what's your general assessment of this patient? Are they doing well? How do you feel about them?
Good.
I heard a brief good, but I don't know if there was anything else that followed with that.
Just a fever is a concern. Otherwise, the saturation and respiratory rate are okay.
Yes, I agree. The oxygen saturation looks good. The respiratory rate is appropriate for an adult patient. And generally, they seem to be doing okay. Obviously, this is not a full patient assessment. I've given you very limited information to do a full assessment and to tell me, I'm okay with this patient potentially going home or not. So let's say the patient looks well, he's talking normally, and the vital signs look great. So if we just look in the simplified kind of FEMAT guidelines, this patient would have mild symptoms. The respiratory rate is less than 24. and the oxygen saturations are greater than 94% on room air. So this patient doesn't meet any requirement for supplemental oxygen right now. Now, once again, there needs to be further assessment, and you would continue on and making sure there were no other red flags with the patient. But from our initial assessment, patient looks pretty good. So we'll continue on with another patient case, and it's actually the same patient, and now he's coming back a couple days later to our healthcare facility. He still has cough and shortness of breath. This time he's on day 6, day 7 of illness, and he seems a little bit more winded when we're talking to him than the previous time a couple days ago. Here are his general vital signs. His temperature is 38.4. Blood pressure looks pretty good at 128/92. His heart rate, he's at 102 beats per minute. His respiratory rate is 24 breaths per minute. And now his oxygen saturation is 88% on room air. So can I ask another audience member to tell me what's their general assessment of the patient? Sick, not sick, could be sick, may need to do something with him.
Patient is sick and needs some intervention.
Yeah, I agree. He doesn't look like he did a couple days ago. There's a couple things that kind of jump out at me as well. One, the oxygen saturation, that's a little bit lower than we like on our patients. And so 88% on room air is going to trigger, hey, we need to do something. And this guy has potentially severe disease where he's going to need further medical treatment. And he's also a little bit tachycardic and actually breathing 24 times a minute. That's quite a bit. As we kind of sit here and are relaxing and watching our Zoom, we're probably hanging out at like 12 to 14. So 24, that's definitely working a little bit more than I would like. So this, if we look at our FEMAT guidelines for reference, this puts this patient in more of a moderate category right now from just the basic information that we went over. His respiratory rate is 24 breaths per minute. His oxygen saturations are 88% on room air. So that means he needs some supplemental oxygen. So we can either do that by a nasal prong or by the Hudson mask, depending upon what's available. Now, if we put the patient on the nasal prong, sometimes I feel like I go into the room and notice the patient's vital sign oxygen saturations are low, and then I have to get the respiratory gear out. It's like, okay, how do we put this nasal prong into the patient's nose and make sure it's secure? And I feel like I always mess it up. And usually the nurse comes in and fixes it for me. So we'll watch a quick video on kind of the tricks of how to place the nasal prong, so you're not like me who needs a nurse to rescue you whenever you place a nasal prong on a patient.
Standard cannula, nothing really special about this. First of all, it will plug in the flow meter, and that's fairly simple. You have to have a Christmas tree, as we showed before. Plugs in right here. I always start the oxygen flow, turn the knob counterclockwise, and let's go with 3 liters here. The ball is at right in the middle of 3 liters. Now I'll show you how to apply it to the patient's face. All right, so now I'm going to apply this to the patient's face. You're going to notice that there is a little bit of a curvature to these cannula prongs, as you can see it. What you want to think about are these going in and following the path of the nasal cavity. The nasal cavity does not go up, it goes back and around. So these things always curve back like this. If you put them on backwards like this, it's going to oxygenate the epithelial cells on the inside of their nose, but not get down into their oral pharynx down to the lungs where you really need. So curving back, I always put it in the nose first, a little bit of pressure. Of course, I'm going to put it around this ear, and then I'm going to show you for this side how it goes over the ear and under the chin. And then this piece right here kind of goes tight. You don't want to go too tight with it, just enough to secure it. And then sometimes I do a little bit of adjustment to what feels best for the patient. One real key, don't do it too tight. A lot of the tubing is now made so that it's soft, because this can cause a lot of breakdown, hospital-acquired pressure ulcers, especially on the tops of the ears. And then if it's real tight across the skin right here, of course the skin's very thin, and then right under the nose, if this is pulled really tight and it's not frequently moved. So this is how nasal cannulas run, of course. It's going to go back into the nasal cavity, and it's going to act almost like a reservoir. So when they take their breath in, they'll pull that fraction of inspired oxygen down to the lungs, and then they exhale and take the next breath.
All right, great. So now we've identified the patient who needs oxygen. We've placed either nasal prongs or the Hudson mask on the patient. Now we need to figure out where we're actually getting the oxygen. So I'll hand it over to Dr. Shanjavan to describe how to use oxygen concentrators.
Thanks, Aaron. So you may be quite familiar with the first oxygen concentrator that's on your left-hand side. That's the ASAP. And we've been using the Oxygen Project has been using this in Fiji since 2016. But as the pandemic progresses, you'll notice more different types of concentrators that come around. So you'll have concentrators that can deliver up to 5 liters per minute, up to 8 liters per minute, or even up to 10 liters per minute. So don't worry, they almost always work the same way. And sometimes many people get a bit concerned when they see so many lights and sounds that come from the concentrators. They're very simple to use, and they're actually made for use in homes by patients who have home-based care. So don't be ever afraid to use these concentrators. They produce a very high purity of oxygen. And you might find one of these in your health facilities, either the Vilbis or the J10s or the Invacares or the newly arriving Oxytex. So you'll notice for the middle one, that's actually got 2 flow meters. So some concentrators come with 2 flows, and you can share it between 2 patients. Thanks, Aaron.
All right, we'll now go to a quick video about how to use one of our oxygen concentrators.
Hola, this is an oxygen concentrator. This brand is the New Life Intensity 10 liter per minute. In your health facility, you may notice many different brands of concentrators, but they all function similarly. Let's learn about the parts today. This is your power button. This is your research switch. This panel advises you of the number of hours the machine has been turned on. This is your flow meter. For this brand, it's from 0 to 10 liters per minute. This is the oxygen nozzle where your oxygen tubing connects, and this panel gives you the alarms. Behind the concentrator, you will find the external filter. When the machine is not in use, once every week, remove the filter, wash it in soapy water, and let it dry in room temperature. Once it has dried, put it back in. And the machine is ready to use again. When using a concentrator, the first thing is you turn it on. This light may turn on, it's normal. It will automatically go off within a few seconds. Then turn up your flow meter to the prescribed liter per minute oxygen flow. Do not go above 10 liters per minute. Connect your patient interface. In this case, we're using a non-rebreather mask. You can connect a nasal prong, or you can even have a simple Hudson mask. Place this on the patient and secure tightly. The reset button might pop out when there is an issue with power fluctuation. When it does, press the button back in and the machine should start working again. This panel contains 3 alarm indicators. The first is the low oxygen indicator. The second is when there is an issue with power supply. And the third is when there is a general malfunction. The first alarm and light may turn on when you first start the machine. Within a few seconds, this will go off. It is normal. If it continues to remain on for more than 5 minutes, discontinue use of your concentrator and switch to your backup cylinder. call the biomed technician and advise them of the fault. The second alarm turns on when there is an issue with power supply. Check the power cord, check the power point, and check to see if there is power supply within the health facility. If this remains turned on, contact the biomed technician for troubleshooting. The third light turns on when there is a general malfunction. Call the biomed technician immediately. Thank you. Before I go into the posters, we always have to remember that oxygen, whether produced from cylinders or from concentrators, are highly flammable. So do not have any open or naked flames near it, do not smoke near it, or do not put any lubrication on the nozzle in order to slip on the patient interfaces, because that could become inflamed. That is inflammable and it could cause a fire, excuse me. So you might have the ASAP intensity concentrator, or you might have the DeVilbiss concentrator, or the Invacare concentrator, or the Oxitec concentrator. They almost always work similarly. And sometimes you may forget what is happening around you. So that's why we've prepared these nice posters. We've kept it to 4 steps as much as possible, and we will circulate this around to your facilities. So I'll quickly just go through this first one so that we can have a look at how it works. So of course, step 1, you would connect the concentrator to the power point and switch it on. And in this case, that's where the power point is, that's where the switch is, sorry. The machine will turn on softly and it'll give off a hum. And the lights on the panel, which is highlighted in the red oval, will flash on for a few seconds. This will turn on, but this will turn off within a few seconds, and that's normal. Step 2 is to turn on the flow meter and go to the desired flow rate. But remember, do not go above the maximum flow rate. So if it's a 5 liter per minute machine, don't go above 5 liters. If it's a 10 liter per minute machine, don't go above 10 liters. And then you connect the concentrator to the patient using a simple mask or even a nasal prong. You have some lights and you have some alarms on the machine. The first light turns on when with a beeping alarm. And when that happens, that means that there's low oxygen concentration. This should disappear within the first 5 minutes. If it doesn't, then just stop using the concentrator, advise the biomed technicians, and use the backup cylinders. If any of the other lights turn on and you don't know what's happening, just call the biomed technician. We're here to assist you as much as possible and whenever. Just a few reminders. Remember to always monitor the patient's saturation as much as possible, and as advised in your guidelines and policies, always keep oxygen cylinders as backup. Remember, do not smoke or keep open flames near the concentrator or use lubricants. And remember to clean the filter once a week, which is placed almost always behind the concentrator. So the next few slides that Aaron will show would be the posters that we've made for the other concentrators, and they have the same steps. Thanks, Aaron.
Well, great. Thank you, Dr. Sanjavan. So let's say your oxygen concentrator, it's working great, but all of a sudden it's not working. The alarms are going off, and now we have to use our backup cylinders, or we just have oxygen cylinders. So we're going to go through how to connect a flow meter and a regulator from the oxygen cylinder.
You first need to ensure that you have the correct type of regulator. Given that we're using a pin index cylinder, we'll be using a pin index regulator. A new oxygen cylinder, so we'll need to first remove the seal, and you can just do that by pulling it up. Please slip the pin index regulator over the pin index cylinder, like that. Make sure that the ports are aligned. You fit that in properly, and you secure the regulator in place by tightening the knob on the side.
This is important because we don't want oxygen leaking from the port. You can fit in your flow meter, but you need to make sure that the oxygen cylinder is closed.
I have here is an oxygen flow meter with 0 to 15 liters per minute. You connect the flow meter, align it towards the port for the regulator, and then twist clockwise in order to secure the.
That the system is securely in place, it is ready for patient use.
All right, I'll hand it back over to Dr. Shanjavan to go over these steps that were reviewed in the video.
Thanks, Dr. Aaron. I'd like to just say those two that were featured, our actor and actresses, are actually our biomedical engineers, and they're on the Zoom session as well. So if you have questions for them, do shoot it across. And I'm just kidding. They might be a bit shy, but yeah, just looking at the steps, it's quite simple to put in a regulator. So for this poster and for this video, we've used the pin index regulator. You may also be aware of the bullnose regulator. So for the pin index regulator, that's why it's always important to identify which type of regulator it is and which type of cylinder you have. So a pin index will go on a pin index and a bullnose will go on a bullnose. So second step is to remove the seal and then simply slip on the regulator onto the cylinder. Make sure that it is upright and the dial is facing the user. Fourth step is to align the ports on the regulator and the cylinder and just tighten the knob, which is showed by the arrow. The fifth step is to put on the flow meter. And so you just align the flow meter and the regulator port and you screw it in clockwise. The setup is now ready to use. You can connect whichever patient interface you'd like and use it on your patient. Thanks, Aaron.
All right, perfect. So now we identified our patient needs oxygen. We've placed the Hudson mask. We've hooked up to the concentrator, which then we had to change to the cylinder. And now the patient's been on oxygen. They're doing better. They no longer require oxygen, and we want to take the patient off oxygen, but we want to also make sure that we're turning off the oxygen so we don't lose that valuable resource. So we're going to review how to disconnect the flow meter and a regulator from an oxygen cylinder.
To remove your flow meter, you need to turn off the cylinder. Then open your flow meter. You'll see the dial going to 0. Your flow will come back to 0. Turn it off. Then anti-clockwise, you'll twist the knob for your flow meter in order to take it off. Regulator, turn anti-clockwise and then slip off.
Yep, so as easy as it is to put on a regulator and flow meter, it's much more simpler to take it off. Just remember two things. The first is to make sure the oxygen cylinder is closed, or else you lose an ER. On the other is to make sure that you have bled the system. So turn on the flow meter and let all the oxygen escape through the flow meter, and the dial on the regulator and the flow meter will come to 0. Once that has happened, you just unscrew by turning it anti-clockwise, and the flow meter comes off. And then on the second step, the regulator also gets detached by turning the knob or the key anti-clockwise. Thanks, Aaron.
Well, that is the end of our session. I'll hand it over now to Dr. Steve.
Thank you very much, team, for a clear presentation of those really important things. And it's hard at one go to take all of these things in, but you guys watching this have been, I think, interacting with this and looking at what's been shown and what's been said, And now's an opportunity to ask some questions. Now, you can put your questions in the chat box, and Anthony is monitoring that. And there's an opportunity to just speak out any questions that you have. And you guys have been very attentive, and we know that time goes by, but we want an opportunity to answer questions that you have. So put them up now, and we can put them to the panel. And just keep in mind too, that you can put up questions after this, so that we can respond. And there will be an opportunity next week to pick up questions that people might have asked that we didn't have a chance to ask or answer now. So I'm going to open it up. If you have a question, put it in the chat or speak out and ask away.
There's no questions currently in the chat box, Dr. Howie, but sitting and waiting. We just need someone to kick it off.
Somebody's asking a question here about a humidifier, making a point about humidification. And I wonder whether Beth, you might like to pick up that question. What do you think about humidification? Perhaps Beth and Dr. Aquila. Tell us what you think about humidification. Do they have to be connected to a humidifier, these patients?
Look, hi, it's Beth here, one of the OSMAT nurses from Australia, also an intensive care nurse. Look, in my experience, certainly looking after intensive care patients, I would say yes, humidification is a big bonus. If you have the resources to provide humidification, even if we can humidify through nasal prongs, and the effect that has is that it keeps the airways moist, and the little hairs called cilia in our airways moist as well, which can promote, it often promotes coughing and getting rid of all of those nasty bugs that might be in our airways. So it's something very similar to, I guess, standing in a hot shower and having that steam around us to help facilitate the movement of bacteria in our airways. So I would say my experience would be yes, humidification is an added bonus where we can.
Naka, Beth, and I want to, and what you're saying is that it can certainly make patients feel more comfortable. I'd like to put to Dr. Aquila, is humidification more of a nice to have rather than a must have? I'm thinking of the person out there who's using a device, using cylinder, using a concentrator, and they don't have humidification available. And you may well be in that situation. And what do you think, Dr. Aquila? Is this more of a nice to have rather than a must have? What would you say?
I think given the situation we're in, I think it's a nice to have. You know, if you're in the hospital situation, we do have humidifiers available, but not always. So I think it'll be nice to have humidification, but in an emergency, you have what's available.
Vanaka, Dr. Aquila. So I think the clear message there is that if the patient needs oxygen, give them the oxygen. Don't let the fact that you haven't got humidification available put you off, because the oxygen is what they need most. If you have humidification, well, that's a bonus and it might make them feel more comfortable, but top priority, give the oxygen. How are we going with questions, Anthony?
There's one there now, Stephen, with for oxygen concentrators. Is this something we need to clean, air filters, etc., on a regular basis or after each patient?
Well, thank you very much for that question. And Dr. Shanjavan, would you like to tackle that one?
Sure, thanks, Professor. Hi, Dr. Donnet, thank you for that question. You have a few types of filters on the machine. The one that we have referred to was the coarse filter, which is at the back of the concentrator. It prevents dust from entering, and it also prevents little bugs from entering and making their nests inside the machine. So you do clean them at least once a week, or even a bit less frequently. But when you do clean them, you'll notice that it has collected quite a lot of dust on it. And it's very simple to clean. You just clean it under running water, or you can just soak it in soap and water and just wash it off under running water. Leave it to dry. It doesn't have to be like extremely dry, but as long as there's no obvious water in it, you can put it back in and start using the machine. Apart from that, there are other sorts of maintenances that you do need to do for the machine. And this is when you need to have the biomedical technician or your supplier involved. And that would mean changing the sieve beds inside or changing the internal filters. In terms of infection prevention and control, definitely, it will be great for you to just wipe the machine down using any sort of alcohol-based wipe. I hope that's answered your question. Thank you.
Vinaka, Dr. Shanjavan, and I think that's a really good answer and helpful. And to the specific question that was asked there, you don't need to, that filter that Dr. Shanjavan was showing in the video, you don't need to clean that after every patient. Now, of course, you want your patients to have clean mask, nasal prongs, but that filter at the back is not something that needs to be cleaned after every patient. If it doesn't get cleaned at all, it can get clogged up, and then the air intake into the machine it can be less than it should be, and it can overheat. So it is worth cleaning it weekly, as Dr. Shanjavan says. How are we going, Anthony?
Yeah, there's no other questions at the moment.
Thank you.
I think I see a question about the concentrators to be used for non-COVID patients after the outbreak.
Erin, would you like to comment on that?
I would say yes. is the easy. I got the easy question, so I'll answer it with one word: yes.
Yeah,
thank you for giving me the easy question.
Yeah. Well, I think, look, thank you for asking the question, because there are no silly questions. And can it be used for non-COVID patients after this outbreak? Absolutely. Absolutely. The key thing is, and when COVID came along, there were people who had respiratory problems, who had low oxygen levels, who needed oxygen before COVID came along. COVID is just one reason why you might need to have oxygen. And there are a lot of others. And absolutely, the idea is that everybody who would need oxygen has access to it, because nobody should be dying for lack of oxygen. So those machines and those sources, all the different sources, absolutely can be used for non-COVID patients who need them as well. So, thank you for asking the question.
And I think the question actually was more as to be, how do they need to be disinfected? So I avoided that. So maybe I will defer to Shanjavan to answer the disinfection. You've mentioned that previously.
There's another question now, Stephen, on the maximum hours that the oxygen concentrators could be used for.
Right, thank you, Anthony, and that's a good question, which I'll come to. But I wonder whether Dr. Aquila or Shanjavan would just like to answer that question about the disinfection. I think we're talking here more about making sure that the mask or the prongs that the patient is using, that those are clean, and that's rather than the whole concentrator, including the filter. But would you like to comment on that, Dr. Aquila?
I think from as you mentioned, it should be, as much as possible, single-use consumables for or at least the sterile new mask or oxygen tubings. But yes, the outside of the machine should be wiped down, and the filters mentioned, as you mentioned, Sanjavan cleaned once a week. The internal filters, I think it just depends on the individual manufacturer's instructions and whether they need to be serviced every at a certain points.
Vanaka, Dr. Aquila, and this is where our biomedical colleagues come in, helping to keep these machines on track. All machines need some attention, but from the user point of view, it should be simple just to follow the guidelines, turn them on, have that clean patient interface with the prongs, the mask, and go to it. And to come back to that question that you were asking, that you were drawing my attention to, Anthony, about the hours that it can be used for. If you have power, the concentrator can just run. Okay, and this is the advantage of a concentrator, that if you have the power, it's not going to run out of oxygen. So that's a big plus. So in practice, it's good to have a cylinder to back up the concentrator, good to have a concentrator to back up a cylinder, yeah, because they have different strengths. So overall, if they're looked after, they can go for quite a few years, up to about 40,000 hours, if anyone was really interested in that. But for practical purposes, you just, if you have the power, you just turn it on and you use it. Anthony, I see a question here on particular considerations if a health facility has inconsistent power or power for limited hours. That's a very common situation. And thank you so much for asking that question. So it's true that for a concentrator to run, you need the power, as we were saying before. So if you do have interruptions to power, so you may, in some facilities where we've been working, there's a solar power that we've put in to make sure that the concentrators can run 24/7. That's one possible solution. But if you don't have that, then you do need to have cylinder backup if the power is out and you can't use the concentrator. So that's the importance of not relying on just one source. You need to have backup for this. So that's— I
was going to say there, Stephen, as well, it's important that if you do have a generator backup for your health facility, that the oxygen concentrator and those types of machinery are put onto the power points that will work when the generator is on. Yes. Because obviously not everything can go on generator power. So having that redundancy in your health facility is very important, especially for these patients.
Really good point, Anthony.
And Sean Javan, you had your hand up?
Oh yeah, I was just trying to add to what Professor had said, that we've actually had concentrators in places that don't have power from the grid. So we have sites like Wainunu and also Lekutu, which have used solar panels. And we've also had places that have used generators on it. It's good also to have a surge protector in between if you can get it. It protects all machines. That's even if you have grid power. Yeah, and it lasts. Thank you.
Great points. Thank you, Dr. Shanjavan.
There is another question, Dr. Howie, and that is there any scenario where a patient who fits into the severe FEMAT assessment category could be treated at home with oxygen supplementation and monitoring?
Okay, thank you, Anthony. I'm going to pass that question directly on to Dr. Aquila to see what you think about that one, Dr. Aquila.
I think that will be quite difficult to monitor, to treat severe COVID at home. I think this is why we advise the general public to present themselves to hospital, because there are some modalities of oxygen therapy that you cannot give at home, and that with these oxygen concentrators, they can only go up to a maximum of 10 liters per minute. And often these patients require much higher flows of oxygen and at higher concentrations. So these oxygen concentrators will not be able to give or provide enough oxygen and flows to be able to manage the severe COVID at home.
Vanaka, Dr. Aquila. And with that, thank you, Dr. Aquila, and thank you to the panel for addressing those questions. And our time is coming to a close, and I just want to just very briefly, just remind us of what we've covered today. Thank you, Erin. So we have looked at the FEMAT guideline, which is the basis for the treatment that these patients should be getting. We've thought about respiratory assessment, including oximetry. And just remember that if you are if your saturation is less than 94, that's not good. So 93 is bad, and less than that, bad. So we've talked about oxygen treatment with mask and nasal prongs. We've looked at concentrators, we've looked at cylinders, we've looked at wall outlets, and we've had to think about how we make sure that cylinders get connected with regulators and flow meters. So it's hard to remember everything from a session like this. In fact, almost impossible. And we understand that. I think we're all in the same boat. So those visual guides that Dr. Shanjavan had produced, we've shown them to you today as a reminder of what we've been talking about, and we'd like those to be out and available to you wherever you are working to help you to remember what to do. We also want to make the links for the videos and the link for this webinar recording available to you to go back and look at, because by any of those means, we'd like you to be able to go back and be reminded, and so that you remember the simple steps to assessing a patient and to treating them. Next time, we're going to be covering how to treat the more severe patients with high flow Airvo treatment, and we're looking forward to you joining us then. And if you have questions in the meantime, we're going to pop up an email address that you can send them to, and we're grateful to Dr. Shanjavan for fielding those questions, and we hope that we'll be able to address those. If you send those through, we'll be able to address those next week in our session. Now, our hosts are hoping that if you haven't got your a video on at the moment, that you might be able to just pop that on briefly so that we can all see you. And I think that they would like to take some screenshots just for documentation around this webinar. And so if you could do that now, that would be very much appreciated. And Anthony, you can tell us when we're okay to move on and to say goodbye.
Can we end the slideshow to have more faces on the screen? Yeah.
Nice. Thank you for that reminder.
Professor,
lovely faces on the screen. Yes, Dr. Shanjavan.
While we're taking pictures, can I just say thank you very much to all the frontliners for doing what you're doing, because it is hard work. Thank you very much. Really, you are doing awesome. Thank you very much.
Vanaka, Dr. Shanjavan, and this is such a challenging time, and just absolutely agree with that. How are we going, Anthony?
Oh, look, I could spend an hour taking photos, to be honest. I've got 3 or 4 pages. And again, yeah, thank you for your guidance and Erin's guidance today, Dr. Howie and Dr. Nost. Much appreciated. I'll hand back over to you.
Vanaka, Anthony, and I think with that, we'll thank our trainers and thank our participants, and looking forward to seeing you next week. Please do join us, Vanaka Vakalevu. And Dr. Pate, can I hand back to you just to finish?
So Vinaka team, Dr. Howie and team. So yeah, we'll bring this to a close now. Tomorrow we're having a presentation on clinical management of COVID-19. So that's going to be another interesting one. And we will also try and share the link for the next set of webinars for next week. And we'll begin again with the high flow oxygen with the team. But again, thank you from the facility. Vinaka Vakalevu, have a good evening to everyone, and we'll see you again tomorrow night. Vinaka.
Thank
you very much,